So thank you so much. Next to introduce Elijah. No pressure, but what you're going to do is, I think, very much impress your own children. They'll probably see you in a very different light. Elijah, it's always been a pleasure to have conversations with you and work together. You originally came from South Africa and then had a wonderful pedigree of attending St John's College, Cambridge, and then moved on to Guy's Hospital. And you've spent quite a bit of your career here at St George's. You have a particular interest in a very important area of unexplained and unexpected sudden death. Your particular element about that relates to cardiology, and it's a marker of the esteem and international reputation that you've become president of the Association of Inherited Cardiac Conditions. It's a pleasure to have you talk to us. I would like to also very much welcome and thanks two people in the front row here, James and Margaret Lancaster, who are supporters of your work and also friends of St George's. So looking forward to the next 30 minutes, and afterwards I'm delighted that Professor John Cann is going to give the vote of thanks. Thank you.
Thank you, Jenny. Please let me know if you don't hear me clearly. I'm going to put this over here, because I tend to gesticulate quite a bit when it gets going, if it'll stay in place. Now, I don't think I can necessarily compete with Nidhi when it comes to Star Wars. That I hadn't foreseen, although I should have picked it up from the title, and so you've beaten me hands down already, so thank you. And it was a fantastic talk and insight into your career, and I really enjoyed it. Thank you so much. And I've noticed I probably should have had a few extra slides of my own on thanks to people so I don't forget. But please forgive me if I do forget. So my talk is entitled Why the Sudden Interest, and you may have seen the posters outside. Please bear with me. The last time I had a good photo taken, I had a lot less grey hair, and so that may explain the slightly flattering appearance there. But it's always nice to look as long as you can think as young as you look. That's fine. So why the sudden interest really is why my interest in sudden death, and therefore I think I should just say a little bit about sudden death to begin with. What is sudden death? Now, sudden death is defined as an instantaneous death, or a death that occurs within 1 hour of onset of any symptoms, or sometimes it may also be a death that's occurred in sleep when somebody's found to have died suddenly and unexpectedly. It's important because it's the most common manifestation, the most common example of how heart disease presents, and heart disease is one of the most common causes of disease and death in our Western societies, and becoming increasingly important across the world. It's also often unheralded, and unheralded means that the person may never have symptoms or signs of heart disease, or signs that they're at risk of dying suddenly, and therefore we need to identify the causes in order that we can identify people who are at risk and then try and prevent that sudden death. And that's the paradigm that I've been trying to work in, the idea behind it. And maybe we could also identify new treatments that work better than the current treatments we have. Why medicine? Now, you've already heard that I come from South Africa, and this is when I was 6 years old in South Africa. At my nursery school, and you could see, or my early primary school, you could see that I was already interested in medicine, or being on the receiving end there as the patient. And I seemed to have a childhood interest in medicine to begin with. We left South Africa when I was 8 years old, but I'd already seen my older cousins moving towards medicines as careers, and they were an example to me, an inspiration that this is something useful to do. This is a good profession to be in. And I'm Jewish as well, and so it's a good Jewish profession as well. So there we go. I also had the great fortune, after we emigrated, and with great sacrifice from my parents, to attend a fantastic school called the Manchester Grammar School. And I had great mentorship and career advice and support, and I was advised that maybe the health professions were for me. And you know what, I agreed wholeheartedly because I'd already had this childhood inspiration. So I went for it big time, and I think I wanted to be a doctor from very early on, as you may see. Now, this wasn't from Manchester Grammar School, this was a bit earlier. This is, my writing's got worse, I'm sorry to say. I fulfill that. But this is something that my mother preserved from that aforementioned primary school. What I want to be famous for, I've inserted one or two words just so that it makes a bit more sense. I would like to be the world's greatest doctor. I would be called Dr. E.R. Behr at the age of 28. I was. It did happen. Happily because all my patients liked me. I started happily because all my patients liked me because they knew I was gentle. I had a patient who was shot in the head and was shot somewhere near the heart, and that was next to the most important blood vessel, and I saved him. When I was 39, I'd saved 2,900 people. I carried on for 5 decades and then I died. So I hope your dreams come true, is what my teacher wrote there. And I think that may be a childhood aspiration, but I never made it to surgery. Maybe that's, thank goodness for that, some may say. But I became a cardiologist rather than a cardiac surgeon or a neurosurgeon for that matter. But clearly I also thought those were great professions to go for. Anyway, I also had great mentorship through my years at St John's in Cambridge and through to Guy's Hospital, where I did my clinical training. And in particular, I can remember very strong support from one of my consultants there who also looked after me as an intern, as a house officer at Lewisham, Gordon Jackson, who some of you may know. And he inspired me towards cardiology in particular. He's a very vivacious and charismatic character and really gave me an interest and an excitement with cardiology and identified for me this challenge. I think cardiology, much like rheumatology, has been at the forefront of science and technology, and offers so many opportunities and challenges to try and improve patient care, and therefore it's intellectually and academically demanding and challenging, and that's something I've always enjoyed. It's also very practical. You can do lots of hands-on stuff in cardiology, including operating. And I just would like to point out to some of my colleagues and some of the staff who may be here from the cath lab, this is a bit cleaner than I would usually be. So obviously I had aspirations to be a bit more of a careful operator than maybe some of you think. I actually think I'm not so bad. So why sudden death when going on to cardiology? Well, I was already aware of sudden death as an entity as a child. Unfortunately, I lost 2 of my grandparents, my father's parents, to sudden death, one in her sleep and the other after his second heart attack. And so I was already aware that you can lose a family member and not be able to have said goodbye, which is a sad thing. It's a tragedy and a loss. It's the most dramatic reminder of mortality, of our mortality. And it inspired me towards personal research, particularly when I was asked to produce a presentation on sudden death and the treatment of sudden death when I was one of the junior trainees of the St George's system back when I joined it in 1997 and then eventually joined St George's in 1999. And this was under the mentorship of my consultants at St George's at the time. First of all, David Ward, who was in charge of a lot of the educational activity then, Edward Rowland, Professor John Cam, who's here today, and Professor William McKenna, who all supported and mentored me in the right direction as far as I'm concerned. I became a cardiac electrophysiologist eventually and inspired me in cardiac genetics and the research of sudden death. And in fact, it was a phone call from Bill McKenna when I was doing one of those practical things, a cardiac catheter lab list in Kingston with Bill Culling, one of my other consultants and mentors. And he phoned up and said, would you like to do a project on sudden death, unexplained sudden death, but the heart is normal and we don't know what the cause is. We think it's genetic, and this is something that could be researched. And this was back in 1998, and I started in 1999 at St George's as a research fellow. And this is what we call a pedigree. This describes a family with the parents at the top and the children at the bottom. The circles are women and the squares are men. And it describes one of my first ever SADS families, the sudden arrhythmic death syndrome, where there's been an unexplained and unexpected sudden death. This was a 34-year-old man who was driving his car with his children in it when he collapsed at the wheel and could not be resuscitated. Thankfully, the children weren't hurt in the traffic accident, but there was no explanation as to why this young man had died so suddenly. As many of these cases go through, a coroner's autopsy was required, and the pathologist could not find the reason for the sudden death. And therefore we saw the family as part of our investigation, and we found that there was an underlying disorder of sodium channels, and these involved in the electrical function of the heart, and a defect in the sodium channels can result in Brugada syndrome and the long QT syndrome, which this family happened to have, and clearly offered a diagnostic challenge. And unfortunately, we did find that a lot of the family members coloured in red were the ones who also carried the condition, but then we were able to treat them and hopefully prevent their risk for sudden death in the future. But I immediately came up against bereavement, and the bereavement is quite shocking in these circumstances, and you tend to appreciate it more when you have your own children, although you could still empathise with it even before you've had your own children. The spouse is left alone and bewildered to some extent, sometimes with support of family and sometimes not. Children are bewildered because of the loss of their parent or a loss of a sibling, and parents are having to bury their child before they have seen their life through and before they have seen their own time through, something they would never have expected. And this brought me in contact with charities in the area, particularly cardiac risk in the young, and Steve Cox, the chief executive, is here, and his mother Alison, who founded the charity, isn't, but I came in contact with them, and they were a profound influence on my understanding of the relationship between the doctor and the patient and the allied professionals and the patient, and how we can best help families. And indeed they introduced me to families as well, and I met the Lancasters, who are at the front, Margaret and James, who allowed me in to give clinical support and emotional support, having lost their own son in such a tragic way. And then they gave back, not only emotionally but also financially, in supporting research, and have been extremely important in my own personal success, and I thank them dearly for it. So what did we actually find out with this research? And I'm first going to focus on the relative importance of these unexpected sudden deaths in terms of the general picture of sudden death. And we started to do our research particularly under Bill McKenna, who was my mentor and supervised me through my degree, but also with the late Mike Davis and Mary Shepherd. Mary's here in the audience today, and we started our collaboration back 19 years ago already, and she eventually moved from the Brompton to St George's, and we continue going from strength to strength. And this BHF study that we conducted together, the British Heart Foundation have also funded some of my research over the years, identified that 4% of all sudden deaths in the 4 to 64-year-old age group were these SADS deaths. So not actually so rare that they should be forgotten or dismissed. They're actually more important than you could imagine, particularly given the years of life lost when young people die suddenly, and the social and psychological trauma that it causes. We then went on to do additional studies, and this time it brought in more collaborators from early on in my career who've become established and important colleagues in my academic life and have moved to St George's subsequently, including Michael Papadakis and Sanjay Sharma, who I'm very pleased to hear as well. And we found that at least 400 deaths a year were sudden in the 1 to 35-year-old age group, and in fact we've revised those estimates upwards to closer to 800 per annum are potential SADS deaths, and up to potentially 1,500 young people dying suddenly from cardiac causes overall across the UK. So we've gradually understood how important this is. We also characterized this work, and my fellows, Greg Meller and Harry Raju, worked with that inside a collaborative group. We identified that males dying in sleep or at rest were the most common presentation of the SADS condition. We went on to try and therefore identify the causes, and there were two ways we approached this, one through family studies and one through genetic studies in people who've died suddenly. The first work was again part of my degree, supervised by Bill McKenna and with the same group including Mary Shepherd and the late Mike Davis, and we saw our first group of 30 families as part of a research study funded by the British Heart Foundation as well, where we undertook basic heart tests and identified genetic electrical heart diseases in around 22% of families, so nearly a quarter of families we could actually find an underlying genetic cause, and there may be other individuals who are therefore at risk. We then moved on to more work that I formed a part of my degree, with additional people involved, including my good colleague Mighty Tommy Esteban, who left St George's and then returned to be part of our group again, and Edward Rowland, another one of my mentors, and Steve Jeffrey, who certainly supported me and mentored me through genetics. And we found that more comprehensive testing, including genetic testing, would identify electrical and heart muscle diseases amongst about 60 families this time, in up to half of those families. And so we're starting to find the more you tested, the more that you would find. We also focused as well on how to manage younger family members, the children in families, because it's a lot to put children through comprehensive testing. And we realized through work that my a fellow and now a consultant at the Royal Brompton, Lenny Wong, and my long-standing colleague Jan Till, who's been an important clinical and research collaborator and a fantastic pediatric cardiologist, we learned that we could afford to do less aggressive testing, be a little bit softer and more gentle with the children in our families, and only give them the opportunity to have the testing that they could choose to have when they were older. An important step from that point of view. We also undertook large-scale collaborative studies as our numbers of families enlarged, and I developed contacts with international collaborators, including my colleague Jacob Feldhansen, who's here today. Thank you for coming. And my colleague Arthur Wilder, who's also here today, representing the Amsterdam group, including Connie Bazina. Arthur and I have also developed a tremendous friendship and understanding, as I have done with Jacob, and these are important foundations to the collaborative work we've done. We undertook genetic studies, and there's post-mortem genetic studies, and we call that the molecular autopsy, that maybe genetics can identify the cause of the sudden death before we even have to see the family. And indeed, we found that in 13% of cases we could find the cause, the smoking gun, and that would immediately help us in terms of assessing the family, because then we combined with that, and this was assessment of about 100 families from 300 cases of sudden unexpected death, and we found that we could find the cause in 40% of families. And we then went on to look at our clinical cohort, meaning our families that we've been seeing in clinics over the years, and this had built up to just under 400 at this point by the time we did this paper, Michael and Stathis in particular, working with all of us together, Mary, Sanjay and myself. We understood that by incorporating systematic adrenaline testing, and adrenaline testing is a type of test where you try and bring out the signs of a genetic heart disease that we've always thought of as being an electrical one, called the Brugada syndrome. And we found that in fact this was the most common diagnosis, accounting for close to a third of our family's causes of sudden death. And Brugada syndrome has become a very important focus of interest for me. We did this previous work as well, Harry Raju and Michael Papadakis working together with Sanjay and I, looking at victims from families with the Brugada syndrome and establishing that if we had actually seen these people before they died, we would never have known they were at risk of dying. They never had signs. Their ECGs by and large were normal if they'd had one done, and most of them had never had a blackout to say they were at risk of dying suddenly. And it really made it imperative for us to find better risk markers, so the future we might actually be able to predict risk better and stop sad deaths from occurring to begin with. And in order to do that, we have to understand the mechanisms underlying Brugada syndrome better as well. This research was undertaken in collaboration with my colleague Kunlawi Nadamani, who's also here today, I'm very pleased to say, with Mary Shepherd and a large collaborative group, including Arthur Wilder. And we studied the hearts from sudden death victims in families who've been diagnosed with Brugada syndrome. And I said to you before, we thought it was a primary electrical disease, meaning we thought it was only down to electricity in the heart, and we only find it if somebody was alive, and therefore we wouldn't be able to pick it up at the time an autopsy was done. What we did find, however, is that's not the case. There's an underlying slowing of conduction in the heart that's down in part to scar and in part to molecular changes in the heart structure, and that if we looked at live patients who had the condition, they had the same changes as well as the deceased patients. And if we do an ablation, something called a treatment where we can destroy the area of tissue that's scarred, then it works in reducing risk. And this is one of the areas for new treatments that we really want to pursue in collaboration with our colleagues, and led by Professor Nadamani. And Brugada syndrome, I could do a whole nother talk and you'd be here missing the food and the alcohol. So and my children would go way past their bedtime. So all I'm going to say is that there's a large body of genetic and clinical research, multi-center collaboration around Brugada syndrome and particularly the sodium channel diseases. And Peter Schwartz, who's here as well, a fantastic colleague, is a participant and a leader in this work that I'm happy to be part of. And I think it's a fantastic group that will eventually give us great answers on how to treat and manage the genetic electrical heart diseases. So I also wanted to move on to talk about another area of interest, sudden infant death syndrome. And this was prompted because some of the families who came to see me in clinic had lost a baby or an infant suddenly and no explanation could be found. And there's been a suspicion that this may be due to genetic heart disease as well. And these are terribly traumatized families and parents, most understandably, and so we want to find the answer for them. And so one way is to try and tackle this with genetics and build on the work that's been done by Peter Schwartz and my other colleague Mike Ackerman in this area. And in fact, we did a collaborative work with Mike Ackerman and Dave Tester from the Mayo Clinic, with Lenny Wong leading from our side, and also collaborating with Jacob Feld-Hansen, looking at the heart genetic causes for sudden infant death syndrome, for cot death. This had always been thought to actually be quite a dramatic cause. Maybe 10-15% of these sudden infant deaths may be due to some of those genetic heart disease we've been finding in older families and older cases of sudden death. But in fact, we revised that estimate down to around 5% based on one of the largest studies conducted so far. This has important implications for family management, because if you can't see any signs of serious heart diseases, you can at least give some reassurance to families about their future pregnancies and future risk in their family. There are also other genes that have been proposed as being involved in the risk for sudden infant death syndrome, and we tried to look at those in this large group of cases, over 400 cases that we were able to study genetically. And Belinda Gray, who's here as well, who's been working with me for a year and a half so from Australia, did this work together with Mike and Dave from the Mayo again. And we looked at these other previously proposed genetic disorders, and we could find little evidence for them being important causes for risk in sudden infant death syndrome. What we did find, however, was a new cause for sudden infant death syndrome by collaborative work with the Queen's Square Neurology Group led by Emma Matthews and Mike Hanna, and again our side being led by Lenny Wong and myself in this collaboration with Mike Ackerman's group. We identified that there was this muscle disorder that can cause paralysis of the breathing muscles, and had been spotted in babies having breathing difficulties, and we actually found out in the end that these babies could potentially be at risk of SIDS, at risk of cot death. And this is important because this is treatable, it's preventable, as are the cardiac conditions, and it seemed to be responsible for 2% of the cases that we investigated. So not only maybe 5% of cardiac causes, but 2% of breathing causes that are potentially preventable if we can identify them prior to sudden death. We went to look more closely, was there anything else in there in terms of rare genetic disorders that could cause sudden infant death, and we couldn't find anything new when we looked at the rest of the important genetic code that we could interrogate, that we could understand. And it's important implications for future genetic studies. We have to, if we think that genetics are causing these conditions, we have to now look at common genetic variation. That's the next step for our research, and the interaction between rare and common genetic variation. Lastly, I just want to touch on another area of research, medication-induced sudden death risk, known to my colleagues in the audience as drug-induced torsade de pointe, and where we've looked at the population importance of it and the genetics of it, and this was particularly supported by John Cam and mentored by John Cam, and I had the fortune to be able to progress and develop a program grant to the British Heart Foundation under his support. That was a major multi-centre effort, and that managed to collect not only clinical information about patients who'd suffered these events, but also genetic information as well. We found that the risks for drug-induced life-threatening rhythm abnormalities in the UK related to being either an older female, having heart disease, having a prior family history of sudden death, suggesting a genetic element, having a low potassium in the blood called hypokalemia, and one particular drug, amiodarone, appeared particularly important, given that it's one of our most heavily used heart rhythm drugs. We also undertook genetic studies, but I have to say that these have been very difficult to undertake, and we've not really had the success we've had in other areas so far, but there may be ways forward by using things called polygenic risk scores to understand the risks for this disorder, and this research was particularly undertaken in collaboration with a colleague from Vanderbilt in the US, Professor Dan Roden. We did have some luck looking particularly at specific amiodarone-related drug-induced torsade de pointe, as it's called. Work with the elder Jamsidi and Steve Jeffrey, as well as Dan Roden, managed to identify common genetic variation as being important. And so now to the future, to the crystal ball gazing. I think the immediate future for us is going to be looking at interaction of rare and common genetic variation on risk, and then its downstream effects in terms of functional effects on the heart and the risk for heart rhythm disorders. And this can be in the genetic syndromes I've already described to you already, but it also in the general population in more common causes of sudden death, such as artery disease, coronary artery disease, and that gives us the opportunity to tap into big data, as it's called. And that's an opportunity that I'll be taking advantage of in the future, because risk stratification in the general population, determining who's at risk and who needs to be protected and what we can do for that risk by developing new treatments, is going to be extremely important in preventing sudden deaths across the board, and not just in rarer disorders. And so that brings me back to my original initiation into the field of sudden death and to the patient, because you can be fixated upon the next manuscript, the next paper, the next grant, the next challenge that comes along in the academic field, but actually comes down to the patient. And so I'm just going to read this email out to you. As a patient on the borderline of requiring an ICD, I begrudged knowing about Brugada syndrome, as this meant I felt like I had to have an ICD just in case something happened. I thought nothing will happen and it was a distraction, but something I should do for my family, and the worry of having something that might happen was very stressful. So on Saturday night, a quiet drink with friends after an exceptionally stressful work week, I suddenly felt very lightheaded, passed out, and had an electronic shock in the space of 20 seconds. The ICD must probably save my life and save me from complications. I was with friends who did not know cardiac resuscitation. My wife and 2 girls, with a third expected, soon have gained a father for another 20 plus years, hopefully longer because he is in his 40s. I always said I would be delighted if it went off, and I am. Thank you and your team for your work on this. It has made a life-changing and positive difference to my family and I. I mean, that's something to bring you back to the importance of it all. The patient and the family are the center of what we're doing, and I've had the good fortune to be involved in guidelines with colleagues who are here, but the guidelines are about the patients and doing better for the patients and the families. I've been had the honor of being on the council for 8 years of the Association for Inherited Cardiac Conditions as a founder member, and then latterly for the last 2 years as the president. But our focus is on improving the outcomes for the patient and for the family. And I've also had the great honour of being part of the European Reference Network, led by Arthur Wilder, with a number of my colleagues here who are also on this. And again, the focus is on the best for the patient, the best for the family, and they're the centre of it. And so let's just maybe reflect now on the overall themes that I've reflected on while putting together this talk, and wanting to think about why I got to where I am and how I got to where I am. I've had mentorship, and I really hope that I've given the same mentorship back to my previous fellows, and I will aim to do my best to mentor my current fellows and future fellows, and they're here. They weren't on the slides because their research is coming out in the future, and they are a source of inspiration for me. There's a personal challenge in academic cardiology that I continue to relish, and hopefully I will continue to relish it for a long time to come. But it's also inspiring those fellows to enjoy that challenge as well, and to want to become clinical academics in the future as well. I've had the good fortune to be able to collaborate with colleagues, both clinical and academic, and on the clinical side, a number of my consultant colleagues are here. One or two are not, and I want to also mention Dr. Tessa Humphrey, is a geneticist I've worked with for many years in my clinics, and also Professor Stephen Brecker, who's been a great support ever since I was appointed at St George's as a registrar, as well as more latterly as a consultant. But I also have great academic colleagues I've spoken to you about already and mentioned here, and also who've not been able to attend today. And I'm grateful for their interest and their motivation and their collaboration. There's a multidisciplinary team that Nidhi alluded to as well in her discussion. We have genetic nurses, we have research nurses, we have secretaries, we have admin staff, we have genetic counsellors, we have lab staff, physiologists, lab nurses, and without any of those individuals, none of what we do in the clinic that informs my research is ever going to happen. And I'm extremely grateful for the collaborative and collegiate way that they always help us, from all the stuff that they do in clinic that we never ask for but seem to demand, and certainly never paid for by the NHS or by anybody else. They work above and beyond what they're expected to do, and because they do it for the patients. And I'm grateful for the patients who've opened up their lives to us, to allow us to help, to allow us to learn, and then to give back, as the Lancasters and other families have done in donating, and to the charities who've supported my research and my interest, including Cardiac Risk in the Young and the British Heart Foundation. I've also been able to develop friendship and trust with these colleagues, and particularly my international colleagues who've made such an effort to come and be a part of this meeting. I did manage to time it with the meeting tomorrow that I'd already invited them to, so that's they explain why they're here. Hopefully they may have come otherwise, but I shouldn't really presume. And just to say again that they share this vocation. They share this vocation for the family, for collaboration, for the patient need, and that's what makes it a great group to work with, because we're thinking beyond our personal careers and our personal interests. We're thinking about what we can do for the future in good science. And I've been through a lot with families, and therefore that makes me particularly aware of the importance of family, of my children who are here, of my parents, of my brother, of my parents-in-law, my brothers-in-law. I'm so grateful for my cousins to be here as well. It indicates the importance of family to me. But mostly I want to say thank you to my wife, because she's been the one who's really seen me through all of this. I'm a soppy dad, as some would say, so I won't do anything else except for I just have to do this. I'm terrible at embarrassing my wife. So thank you to my wife, and thank you to all for bearing with me for what's been quite a long and disturbed day. But thankfully the fire alarms have gone away and we can enjoy something together. And I look forward as well to hearing from John. Thank you very much.
Well, thank you very much, Elijah, for a splendid talk this evening. It was the second splendid talk. We've had a really good evening of academic insights and family insights. I think we have to understand that these occasions are really fundamental occasions for a university, for a medical school. We have to understand the people who work in the institution, their families, and all their colleagues, nationally and internationally. It's a great privilege for me, Elijah, to stand here and give this formal vote of thanks. I have to point out to your family, your friends, and your colleagues that, of course, you're not only a tremendous scientist, but you're also a very fine physician. And I think we all heard that in what Elijah was saying to us this evening. And you're also, of course, a tremendous friend. And we all admire all of those qualities in you, Elijah. And it's wonderful that you are now joining the senior academic ranks at St. George's. I'm really pleased that you're doing that just as I'm falling off the end the other way. But I'll still be around and I'll still be there to give you as much help as I can. I wanted to emphasize that you're now an international person. You're not just St. George's, you're not just the United Kingdom, but you're international. We spent 2 days ago a day in the heart of Leuven University in Belgium, where Elijah was being introduced as a new board member for the European Heart Rhythm Association, which is the largest single body and the most productive single body in the European Society of Cardiology. That is a wonderful achievement. I know you're representing many of your colleagues here, those who are interested in electrophysiology and genetics and sudden death. And we are really pleased in the European Heart Rhythm Association to have you on board as well. So, ladies and gentlemen, friends, family, and colleagues of Elijah Behr, please give him your welcome.